Welcome back, and I hope everyone in person and at home had a great lunch, and for those of you here in person, had a chance to network and check out the exhibitions. Before we move on to our third session, I'm thrilled to introduce our new Chair of Trustees, Cathy Evans, who is joining us for the first time at this year's conference and would like to say a few words. Can you please join me in welcoming her to the stage?
Thank you, and welcome to the afternoon session of the Professionals Conference. I've been Chair and Trustee of Retina UK for 10 days, and it's been a very good 10 days. We've had the Trustee Board meeting, we've had the AGM, and now we have the conference. And you might be interested to know that an astounding 362 people have registered for today, which I think is really quite fantastic. My role is a volunteer role. My last paid role was as Chief Executive of the Royal College of Ophthalmologists. And through that role, I had some knowledge of Retina UK, and I always admired it. But since I've become more involved with Retina UK, my knowledge of it has grown a lot, and my admiration has grown as well. And I have started to think of it, instead of it as an it, but as a we and an us. And we are a small but mighty charity with a small but mighty staff, wonderfully led by Tina, and fantastic supporters and volunteers. And while we're small, we do have big and mighty aims, and they're just two of them, but one is to fund research into inherited sight loss and to try and understand the causes and look for potential treatments. And the second mighty aim is to support people affected by inherited sight loss by offering practical information and emotional support. And I think the testimonies we heard this morning were really inspiring, and I think we've got a clear idea of what the charity is able to do on that front. Of course, the charity can't do everything on its own, and on behalf of Retina UK, I would like to pay tribute to all the work of the professionals in the room and online, and thank you for your dedication and commitment. The charity will be celebrating 50 years next year, and I hope we meet again, and I hope that I can confidently tell you about all the plans that the charity has to celebrate that extraordinary milestone. So I just want to conclude by thanking you for coming, and to say I think we're on the verge of some very interesting times in the sector, and I'm very pleased to be involved with Retina UK. So thank you very much.
Before we move on, I would like to now introduce Retina UK's Research Development Manager, Kate Arkell, to introduce our next session.
Lauren. There's a lot going on in inherited retinal disease research, including at the clinical trial stage. As I said last year in the research update I gave, we're at a point at the moment where things look really exciting for the future, but at the same time, they're still really frustrating for those in our community who are desperate to stop the progression of their sight loss today. Most treatments are still just that bit too far out of reach. For those of you not able to join us last year, you can watch my session on our YouTube channel in the 2023 Professionals Conference section, and that will give you a flavour of what's going on in clinical trials. Professor Graham Black will be here tomorrow, as others have mentioned, to give an update to our community at our annual conference, and again, that will appear on our YouTube channel later. And we do have ongoing updates as well, so keep an eye on the research news section of our website, and look out for research news roundups in our newsletters as well. But the current reality is that for those in our community who want treatments, there's not going to be anything available in the next few years. And they must continue to live with progressive sight loss. So it's really important that professionals and sight loss organisations understand the impact of these conditions on day-to-day life, and that we tailor our services accordingly. In addition, when therapies do eventually reach regulators and NICE, there will need to be really good evidence of the personal and societal cost of inherited retinal conditions to ensure that we end up with accessible NHS treatments for our community. We need robust studies that can capture the impact of these diseases, their impact on lived experience, in a way that works for regulator and payer assessments. So I'm delighted to introduce you to Matias Segovia, Deputy Clinical Research Nurse Manager for the Oxford Eye Research Group. He's going to talk to us today about the EXPLORE-2 study on the impact of retinitis pigmentosa on patients and carers. This study particularly focused on X-linked RP, which is caused by a gene located on the X chromosome and occurring predominantly and certainly more severely in males. After the presentation, Matias and I are going to discuss how professionals can best facilitate research participation, and then we'll have time at the end for your questions on both the EXPLORE-2 study and around research participation and how you can facilitate that. So please join me in welcoming Matias.
Hi everyone, thank you Kate for the introduction, and thanks so much for having me another year here. I'm very excited to be presenting here in Retina UK today because I'm very passionate about the work that I do and the work that my team does. I'm going to start describing a little bit about our team. As the chair just said, the Retina UK is a small and mighty team. We just say the same thing. We are a team composed by research nurses, research coordinators, our clinical lead, Professor Susan Downs, photographers, optometrists, and we all work towards the same goal, which is delivering good quality research to patients and willing participants. Our group was formed in 2008 by Professor Susan Downs and our current manager, Alexina Fantato, and it has grown eventually to what we are today. We are a participative team. We are very independent. We know what we're doing. We have a great lot of experience with inherited eye disease, and we're very passionate about it. We do a lot of work, mostly in inherited retinal diseases, artificial intelligence, age-related macular degeneration, diabetic eye disease, and also uveitis, amongst other specialties. We help our consultant body in the Oxford Eye Hospital to set their trials up in our trust, as well as sponsors to set their trials and gather participants from our pool of patients. We have experience with all study phases, and we currently have 23 ongoing trials with 11 that are going to come up soon. And lately we have noticed that a lot of other clinical trials for other specialties, such as oncology, hematology, respiratory, gastro, etc. Their drugs have side effects in the eye. So we support all of these specialties in their ophthalmic assessments. In the last couple of years, our research manager and our research team have been focused on delivering quality research into the underserved communities. We know that traffic is horrible. Getting to the eye hospital is a challenge sometimes. It'll be great if we can deliver good quality care and good quality research in practices, GPs and optometrists, and we're looking into that in our area. We have liaised with GPs to establish a communication pathway, and we have created a pathway to be able to enroll GPs to find suitable candidates for our trials. We have liaised with lots of charities, with Retina UK and others, and we have also been very close in touch with optometrists, with the Royal College of Optometry, and we enroll them into a survey to find out their interest in research. If you want to find out more about this, please come and have a chat with me. I will be more than happy to give more information. So how do we as research nurses and research coordinators help the consultants and the outpatient staff into recruiting patients for trials? We are the ones usually that liaise with doctors and inform them of other doctors' clinical trials. They also speak amongst themselves, but we are the ones reminding them in clinic. We have this clinical trial going on. We are looking to recruit participants, and we review the referrals that we receive. We review the images that you sent us, and we assess basic eligibility, then transferring it on to doctor. We review all of our clinics to search for suitable candidates, and we review the history as well. We team up with the clinicians, and after we have the consent from the participant, we review basic eligibility criteria to check that the patient is eligible to participate, and then we approach them with information about the study that they're interested in. This slide I actually stole it from Professor Susan Downs. This is something that she uses in every one of their presentations. On the left-hand side, you can see the fundus photograph of an 11-year-old boy's retina. This little boy has an inherited eye disease. It's retinitis pigmentosa, and you can see how early the retina is affected. On the, actually, yeah, it's your right-hand side, sorry. This is a self-portrait of that little boy that he made for Professor Downs. You can see how it affects his vision at such an early stage. We can see with this example, I mean, we've been hearing it the whole morning, how it really affects their life and every aspect of it. So this is why we do what we do, and this is why it's such important to find treatments and carry on research studies to be able to help them. Now, Kate has already explained briefly, so I'm not going to go into detail. And most of you know about X-linked retinitis pigmentosa. But for this particular study that I'm going to discuss today, I just want to mention that it's among most severe forms of retinitis pigmentosa. It's a progressive degeneration of the retina, and usually starts in childhood, leading to legal blindness at 45 as an average. We know the implications for patients and their caregivers. We know that it's physical, emotional, and financially difficult for them to suffer from this condition, but there is limited evidence on the humanistic and economic aspects of this disease. So this is why the company Johnson & Johnson decided to look into this, and they carried out the study about the humanistic impact of X-linked retinitis pigmentosa. And I'm going to present the results of the study because I think they're really interesting and they're very linked to all the discussions that happened earlier today. So this study was called Explore 2, and it's a retrospective review of surveys provided to patients and caregivers in 10 different countries. The primary objectives of this study were to explore the relationship between the clinical stages of X-linked retinitis pigmentosa. They were assessed as mild, moderate, and severe, and the associated clinical, individual, and societal burdens in a real-world setting. And the secondary objectives were to describe the disease pathways, the individual, social, and economic burdens in patients and in caregivers, and the impact on the disease on caregivers. The methods they took to carry on this study were surveys. This was carried out in 23 different centers in 10 different countries. They recruited 169 participants and 69 caregivers. The data was collected from, as I said, surveys to both patients and caregivers, but also retrospective data such as images and medical history and ophthalmic history for up to 5 years prior to the consent to the study. So in this slide, it is a bit messy, so I'm going to explain it as best as I can. I'm going to describe the outcomes for the patient-reported surveys that they carried out. There were quite a few, and the patients were able to give feedback on their condition and the different aspects of their life. So we are quite lucky because the sponsor recently presented the actual results in Retina last week in Barcelona. So I have the actual numbers to be able to share with you. So if you give me 1 second. Yes. So as I said, they reviewed a total of 168 participants. The interesting part of this is that they found out that the mean age of diagnosis was 33.4 years old, which is quite late. And they noticed that the mean time to receive a genetic test result was 252 days, which is incredibly long wait. We can understand with this information how distressful this can be, these long waiting times. And this is actually a wake-up call for us to be able to look into this and be able to provide a better service for our patients. They also noticed that the ophthalmic assessments that the patients received and were performed on their clinical visits to their eye care providers were usually their normal visual acuity, their normal slit lamp examination, and an OCT, which is a scan of the back of your eye. For this group of patients, as you might know, the visual field is what's most affected, and this was assessed only in less than 41% of the patients on all their visits. On the first questionnaire that the sponsor carried out, it's called Modified Low Luminance Questionnaire. It shows 6 domains, and they are driving, extreme lighting, mobility, emotional distress, general dim lighting, and peripheral vision. And they found out, with no surprise, that they were all affected and they were significantly correlated with the severity of the disease. The most affected one was driving. Another questionnaire that was carried out was the Hospital Anxiety and Depression Scale. There is a significant correlation with depression and the stage of the disease, but there's no significant correlation with anxiety, even though 45% of the participants reported some level of it. So the key points that I want to stress as well is that 2/3 of the participants with mild X-linked retinitis pigmentosa and almost 95% of those with severe and moderate reported impacts on mobility and daily activities. This is almost most of them, and we can understand how this can affect every other aspect of their life. They rely on caregivers, 46%, and they stated that they need at least 24.8 hours a week of support from caregivers. If we think of a full-time job as 37.5 hours, this is almost another full-time job for caregivers. They also looked at the financial situation and the impact, and they noticed, and this is in euros, that the money spent due to X-linked retinitis pigmentosa was around 306 euros. Yeah. And they also looked at the caregivers and the impact that they have due to taking care of one relative or family friend with X-linked retinitis pigmentosa. And it's really shocking to say that 75% of these caregivers were full-time workers. Let me find the data exactly so I don't say something incorrect. They reported spending a mean of 28.7 hours per week caring for their relatives. So we can understand how this will impact their life. They also inform that this impacted on their work, on their ability to do their tasks, and they had to take some reductions in work hours and salaries. They also looked at the depression and anxiety scale. 23% of caregivers reported depression and 46% reported some anxiety. And this concludes that nearly half of them have some level of anxiety. They also did a questionnaire to look at the quality of life, but this was not sensitive enough to produce any results. Yes, I've discussed all this already. So, as a conclusion from this study, the importance of doing observational studies which reviews the impact of the participants from their condition and the caregivers is immense. I cannot stress it enough. We are very focused and we're very driven into finding a cure for conditions. But while we do that, we mustn't forget that we also need to look at ways of, while we find a cure, make life easier for our patients and for their caregivers, providing them the support that they need and looking at their needs. This study stressed that we have maybe holes in the system that we need to look at to be able to provide the best care possible. Yes, so I just want to finish with a QR code on the screen. If you scan it, you will be able to go straight to our website in the Oxford Eye Hospital and register your interest to take part in our clinical trials. We have lots going on and we will be more than happy to hear from you. I'm also leaving you with my contact details, just in case you want to get in touch with me, ask me any questions. And yes, thanks so much. Sure.
Thank you so much, Matias. it's striking how clearly the results illustrate that correlation between the degree of sight loss and the impact. We know from our experiences at Retina UK how much the anticipation of future impact can really affect people's mental well-being. And you mentioned the depression and anxiety scales, which I think probably went up even at earlier stages of the disease. Do you think that reflects a little bit of that anticipation and fear for the future?
Definitely is related. I have been talking with some people today as well, and they described how distressed they were, not knowing what was going to happen, or we've heard about it today. They were in denial, they didn't want to even think about it. And when you start, I cannot say because I have not gone through it, but from feedback from patients, when the condition starts to progress, definitely the results show that their anxiety levels and depression and the anticipation really affects them and their livelihood. They have to think of all of these other things that will impact their condition.
Yeah. So I think a couple of people have already mentioned this morning that Retina UK will be repeating our own survey of our community early next year, which goes quite heavily into mental well-being and activities of daily living. So it'll be interesting to see how our results reflect these results, albeit in a less scientific way. So moving on to the wider issue of research participation. Unlike many people affected by eye disease, the vast majority of those with an inherited retinal condition have no options for treatment. And the eye care support pathway, which we heard about earlier, indicates that those with untreatable conditions should be told about clinical trials and other research participation opportunities that are relevant to them. Matias, what do you think patients get out of taking part in studies?
Yeah, so this is a very good example of a study that doesn't give you a treatment, but it gives an outcome for the general disease area, and it will provide better areas of research and actions for the future. Even though you take part in studies that provide treatment or not, you always get the benefit of being followed up more regularly. As you've seen, we're a small team. We know all of our patients in all of our clinical trials and clinical studies, observational studies, and we have a very close relationship with them. We see them regularly ourselves, so they know who to go to if they have any issues. So I think that's a very good benefit. You will be followed up quite regularly in different visits. You will have different assessments performed. And if there's something going on in your eyes, we'll spot it in action. That's another benefit. But yeah, I think the most important is that you are providing your time and yourself for the future treatment for your condition. And
there's perhaps some psychological benefit to that.
Well,
that
yes.
Outweighs maybe a tiny bit.
Yes, yeah, definitely, and I've seen that as well in patients that have had not much going on, and for them to be able to do something and productive and sometimes even get out of the house, that really makes a difference to them, and being able to provide for the wider disease area, that's just makes a difference.
So, Matias, a big part of your job is obviously talking to people about taking part in research. How do you start talking to people about the risks and the benefits of research participation?
So, we're usually guided by our consultants. They are the ones starting the initial conditions and identifying patients. But if we receive phone calls, or if we are contacted, or we see patients in clinic, then it's up to us. Sometimes it's a little bit difficult because we're not clinicians, but we do our best. We have the experience and the knowledge from discussing it with other patients. I think, as you said, it's very important to stress the risks beforehand and straight away. and the benefits come after. The patients need to make an informed decision if they want to take part or not. And it's also very important to say that even if you agreed to take part, you can always withdraw. And your care will not be affected. We're part of the NHS. You will be always taken care of. If it's not by the clinical research team, it'll be by the outpatients team.
Yeah, I think that's really important for our community to understand. They're not making some black and white decision. They can always change their minds. Can you just tell us a little bit about the difference? So when our audience today are talking to their clients, what's the difference for them in terms of taking part in an observational study like Explore 2 or versus an interventional study?
So the difference is quite significant, actually. An interventional study has more risks, most likely. Has probably maybe more benefits if the drug or whatever they're investigated is successful, but has also a bigger commitment. There are a lot of visits, a lot of assessments. It takes a long time for each visit to take place. Our capacity is not great, so we have just a small window to schedule appointments. We will see you very often. You will get tired of us. But yes, we will be there to support you through the whole way. Then observational studies, that's different types. There are survey studies like this one in which we gather data retrospectively and then just perform the surveys. There's some other studies in which we just see you one day, we perform some tests and gather data, and that's it. But there's some other observational studies in preparation for interventionals in which we will see you very regularly, lots of assessments as well, to check your eligibility for future treatment under a clinical trial.
So the level of commitment obviously varies a lot. Is it harder to get people to commit to observational studies?
Yeah, sometimes. If you don't explain properly the benefits of the study, people might think, well, why am I doing this? That's why you always need to be clear on that. But if you do explain it properly and explain the importance of it, then people usually are quite happy to be part of. And again, it gives them a sense of, I'm providing to the community my time, and yeah.
Yeah, so it's quite important. Not all the professionals in our audience will have such an in-depth role in clinical research, but it does matter how professionals speak to potential participants about research in terms of their engagement. If you only have a small number of places to fill, how do you prioritise people for enrolment? Do you look for diversity in the population? Are there...
Yes, we do. We look for diversity, but also we look, usually clinical trials with small numbers are usually interventional, and they got very, very strict criteria. We usually do not have an issue having to prioritize patients and having to leave patients behind, because it's so strict that there's only just a few patients that can take part, which you also need to make sure that the patient expectations
I was about to say, because I think we can all play a part, and I'm conscious of this as well when I'm speaking to people, is talking about clinical trials and how few places there potentially are per centre. And actually in the UK, in a particular trial, there may only be 1 or 2 centres.
2 or 3,
so I think it has to come into the conversation about research participation, because to get people's hopes up.
Exactly, yes.
It's obviously not ideal. Have you ever had a study where the criteria are so tight that you've had to go outside of Oxford? I mean, do other professionals, the wider community of professionals can help you, presumably?
Yes, please. That's why we try to reach community, optometrists and GPs to help us recruit. We live in Oxfordshire, but we can actually recruit patients from all over the country. As long as they have a GP and they register on a GP, we can get a referral and they can come and see us and discuss participation. So yes, please, if you have any patients, those are my contact details, and I'll be more than happy to assess them.
Yeah, I was really interested to hear you say actually about how Oxford is reaching out to GPs. That was the first time I'd heard you mention that, and I think that's a really, really great initiative. Is Oxford doing anything to encourage other centres to do something similar? Because presumably you're reaching out to Oxfordshire GPs. Do you think there's potential for that to happen nationally?
Yes, so in the last NIHR meeting, which is the National Institute of Health and Research, the last conference, there were a few talks about other NHS trusts doing exactly the same thing, reaching out to community, because some of the conditions, and for example, dry age-related macular degeneration, there is no treatment at the moment approved in the NHS. So they're usually seen and discharged back to the community. So if we have any trials coming up, we don't have the pool of patients to review and recruit. So we need to reach out to these communities. We need to speak with GPs and local optometrists to be able to refer those patients back to us.
So going back to the team at Oxford and thinking about our audience, do you talk to patients about research and participation in research even when you're not trying to recruit them? And would the consultants or the ophthalmologists perhaps raise that? And if so, when?
Yes. So usually it's the ophthalmologists. We have a separated team, and this is just Oxford itself. We have a separated team that carries out all the normal outpatients appointments, and then we carry out the research appointments.
Okay.
If we are out in clinic and we have screened the patient's list, then we reach out to the ophthalmologist, seeing that patient, and we inform them that we would like them to approach them about this study that we have, and we keep on reminding them to do so. But normally, if an ophthalmologist believes that a patient is eligible, they will approach them themselves. Our consultant body is very well aware of our ongoing research, and they are a team and they liaise with each other to be able to meet the recruitment targets and give research to our patients.
So anyone in our audience today, including those who don't necessarily work in a clinical setting like you do, could potentially raise research participation in the conversation, and the support pathway does emphasise the importance of that. What tips would you give our audience today on talking about research, or just raising it, or just grabbing opportunities to talk about research?
Yes. Usually we think of research as, well, not we. Usually some people think of research as this magical solution for things, but normally that's not the case. A huge percentage of the clinical trials that take place do not come to fruition, but that's the way research works. Even if a trial has not been successful, it provides us information to be able to learn and to develop other clinical trials to find other ways to treat conditions that are uncurable. I will ask the professionals here today to look out for your local eye clinic. I'm sure all of them will have a website. If they don't, they will have somebody to contact to ask what clinical studies are ongoing in your area. One good tip that I always give is clinicaltrials.gov. It lets you search for clinical trials for different conditions and in different areas, in different countries, and also contact your charities like Retina UK to be able to provide support, and that's how we raise awareness.
Yeah, so I was going to sort of come on to, if somebody's supporting somebody who's not at a major research centre, can you just explain a little bit more about how the research register works? Because quite often people are out regionally, they may not be near a major centre. Mm-hmm. If you live anywhere you can join the research register.
Yes.
And
you can join the research register anywhere, as long as you register on a GP.
okay, so it doesn't mean you're changing your consultant
No, you're
necessarily.
not at all.
Yeah.
No. This is just registering your interest and stating your condition, so we can contact you and inform you of ongoing clinical trials that could be applicable to you. We will not be your main consultants. Your consultant will still be the same, but we will take care of you if we enroll you in a clinical trial.
And if somebody hasn't seen a consultant for a while, they've got a GP, then they perhaps see a member of our audience today more regularly, but they're not seeing a consultant regularly. Does that matter, or is it?
It doesn't matter, as long as you can give us basic information. We can then contact you and liaise with you. Usually when this has happened, we would ask you to, if you live far away, we would ask you to see a local optician, get some scans done, your vision checked, and just send it to us so we can assess eligibility, and we don't have to make you come all the way to Oxford to do that. Yeah.
Okay, and I think Moorfields do something very similar that people can find online if people are nearer to London. Are you aware of, I'm not aware of any other centres that have only Oxford and Moorfields. Are you aware of any others? No, but it's worth asking. Maybe it's something that you can encourage your local centre, particularly the larger ones, to do. Retina UK also has something called the Lived Experience Panel that I think has been mentioned by my colleagues this morning. Anybody is welcome to join that. It consists of community members who have expressed an interest in contributing to research-related activity and are happy for us to email them when we hear about opportunities. When we hear about opportunities, they tend not to be interventional studies, they tend not to be clinical trials because the centres have so few spaces, they usually manage to recruit by themselves, but they often include smaller studies, also things that people can do from home. So quite often we get asked to share surveys and things like that, and these still make a difference. That lived experience can be shared via a computer, so still worth doing. And people can join that online. There's a form online that people can fill in, or they can give us a call in the office, and that's just one small thing that people can do. You can signpost people to feel they've taken a small step towards perhaps contributing something to research. That's kind of the end of our discussion. We'd love to take your questions on both the Explore study itself, so the data that Matias presented, and about research participation. We've got.
Hi, I'm Alba, and Echo in Oldham. I think, what the study that you've presented kind of confirms what we already knew as professionals and as people with lived experience, but what's going to happen next? Like, what are the plans to improve that emotional health that people are experiencing?
I couldn't hear the question.
Yeah, so I think what happens next, the outcome of a study like this obviously really clearly demonstrates the impact on emotional health and what happens with these results. What's the purpose for the study? Is that right, Alba? Is that
Right? Yeah.
So, well, we kind of know that patients and caregivers are impacted, but we don't know at what extent on paper. This proves to regulatory bodies and to people developing treatments that something is really required to help these participants and patients. And this will be a good starting point for all the clinical trials developing a cure for this condition, and also a good conversation started to improve the system in the different countries that the study took place.
I think it's important as well that we have really solid data when we're having conversations with those who are providing services at a national level or local level, but statutory services. And it's really important that we have really solid data to go to those organisations with, because they don't really like anecdote very much. And we know how much these conditions impact, but studies like this put some numbers around it. What was
Oh, is it on? Okay. I think it also links in quite well with the support pathway they were talking about before,
Yeah.
because it would make a difference to people's emotional health if they had had that support before at the time of diagnosis. So I think it could link quite well with the support pathway they explored study.
Yeah, it'd be interesting to see actually after the support pathway is implemented, and hopefully if it's running really well, if the data in the UK
Changes. Yeah.
Is there a question?
We've got one from home.
Yeah.
So do people get paid to take part in these research studies, or can they at least claim expenses?
Yes. So I can answer that question. It depends on the study. It depends on the sponsor of the study. And when a sponsor does an application to do a research in the UK, they need to state this before they even consent the first patient. If they have recommended that they would like to pay for the participation, then it needs to be approved by an ethics committee. But that's not the case for all the studies. Usually for interventional ones, you see online that some studies with greater risks do pay, but normally interventional studies, and I'm talking about my site, the sponsor pays for transport and overnight stays if are required. They reimburse for food if you're staying with us for however long you're staying. So it depends on the study, but you will be informed before you sign the consent of what's...
I think it's quite probably important. It's a good opportunity to mention the difference between a proper clinical trial and perhaps some treatments that are offered elsewhere around the world that are not regulated, where people are being asked to pay vast amounts of money, and it's being called a clinical trial, and it's not.
Yeah.
So mainly, I think we're looking at expenses being covered, but people not paying, certainly not paying for the treatment that's involved in the trial. There was a, did you?
Hi, it's Lydia here from Guide Dogs. I suppose this comes back to the earlier question from Alba, and maybe should have asked it this morning to do with the pathway, but are we going to evidence the impact of the pathway to see the difference that makes for people's well-being and outcomes in life?
Have we still got Denise? Is Denise in the room still, or somebody?
Hi, this is Paula speaking. Yes, is the simple answer. There's certainly going to be some baseline measurements taken within healthcare settings to understand what the current picture is. Obviously, we need to understand that baseline before we can build on it, but it is something that's very much being considered through the development and the rollout of the pathway.
We have got another question from home if there's...
Andy's got a question.
Hi, my name is Andy Byrne. Andy Byrne, I'm also in drug development. A quick question. With the kind of the exploratory quality of life research that you've done, have you had a chat with the MHRA about how, or even NICE, about how these kind of studies would impact their view on new treatments coming down the line? Because I think one of the hardest things we have is really quantifying the impact of quality of life. You know, if we bring a new RNA therapy to USH2A individuals or LCA10, these kind of studies are really important about shaping the whole impact on someone. But have you had those conversations with the regulators or even health technology assessment?
Yeah, so as I'm not part of the sponsor team, I'm just one of the members of the team in one of the sites. I haven't had those discussions with the MHRA or ethics committee or any of that, but I'm sure that that's the whole point of it, to make sure that they have this data, and as Kate said, that they got the numbers and they can prove that whatever they want to develop is required. So I'm sure it will be beneficial for any condition that it's in the same lines of this one. Yeah.
And that's an area of work that Retina UK is now starting to develop, and we will be engaging more actively going forward. As these treatments come through, we've realised that's an area that we need to address, and we will be playing a part in representing the voice of our community with the regulator and with NICE, so that we get these treatments through to our community. But it's going to depend on data and what we can tell them, and how we illustrate the impact of these conditions. Thank you. I think... Have you got a question, Matt? Sorry.
I have. Are there opportunities for children and young people to get involved in research, or is it just for adults?
Children and young people. Do you ever have trials for...
Yes, we do. You can join our research register and we will contact you if there's a study that's applicable to you. Our website is due to be updated, and we will list all the ongoing clinical trials and we will be more on top of it, but yes. That's
so can parents join their children?
Yes, exactly.
Onto the Oxford Research Register?
Yes.
Okay.
Yes, yeah.
Thank you. Okay, thank you very much. I think we have a break now, a short break. Lauren?
Sorry. Yes, we do. Thank you both. Thank you so much for that. We are now going to a break. Oh.